Hello students, whenever I mention ABG, arterial blood gas, or ABB, acid base balance, this will be expression of majority of these students because it is mathematics. We all hate mathematics, that's why we have come into MBBS. Now mathematics is back with revenge in the form of acid base balance, arterial blood gas analysis. One good thing about mathematics is it is formula based. So if I say 3 plus 2 is equal to 5, even if you write 2 plus 3, 4 plus 1, 5 plus 0, the answer will be the same. In the same way, in ABG analysis also, there are certain formulas. If you know how to apply, where to apply, life becomes very easy. First, let us see the basic terms. To understand ABG, you should know simple chemistry. What is pH, what is acid, what is base. And mathematics, addition, subtraction, multiplication, nothing more than that. Have you ever imagined what is meant by pH? pH in English means power of H plus. How much H plus is present in your body? So it is written as negative logarithm of H plus ion concentration. So this can be also written as pH is equal to log of 1 by H plus. Now with this background, what will be the relationship between pH and H plus? It will be indirect relation. So it means because of some disease, if H plus is increasing, automatically pH will decrease. So because of some disease, if H plus is increasing, automatically pH will reduce. Anywhere reduced pH is referred to as acidosis. In the same way, because of some disease, if H plus is reducing, automatically what will happen to pH? It will increase. It will increase. So in the same way, because of some disease, if H plus is decreasing, pH will increase. Anywhere increase in pH is called as alkalosis. Now for all practical purposes, acidosis or alkalosis will only do with respect to pH, not with H plus. Because the absolute value of H plus is in multiple decimals, it is very difficult to represent. So anywhere decrease pH is acidosis, and pH is a whole number, you can easily represent. And increased pH is called as alkalosis. Now what do you mean by the term acid? Acid in chemistry means some substance which is aggressively giving H plus. Acid definition is molecule that can give H plus. Why is HCl a very strong acid? Because it will quickly give rise to lot of H plus. But in your body, abundant acid is not HCl. Most abundant acid is carbonic acid, H2CO3. Where is it produced from? CO2. In my body, most abundant acid is H2CO3. It is produced from CO2, and that is responsible for lot of H plus. Because CO2 is the major source of H plus in the body. CO2 automatically becomes the acid in your body. Now because of some disease, if CO2 is increasing in your body, automatically what will be excessively produced? H plus. If a H plus increases, pH will reduce. Whenever pH is reduced, what is that phenomena called as acidosis? This is due to CO2. So this should be called as respiratory acidosis. Now because of some disease, CO2 is not at all formed in your body, or there is less CO2 in your body. When CO2 is not there, what will not be produced ultimately? H plus. if a H plus reduces, automatically pH will increase. Anywhere increase in pH is referred to as alkalosis. This is due to CO2. So it should be called as respiratory alkalosis. In very simple words, CO2 retention is respiratory acidosis, whereas CO2 washout is respiratory alkalosis. With this background, what will be the relationship between pH and CO2? Observe here. If CO2 increased, pH is reduced. If CO2 decreased, pH is increased. So the relationship between pH and CO2 will be indirect. pH will be inversely proportional to CO2. Then you must be knowing acid and base are two mutually opposite phenomena. Acid is something which can give H plus. Opposite word of giving is taking, accepting. So the definition of base will be molecule that can accept H plus. Now why NaOH is considered as a very strong base? Because here OH minus will quickly eat up the H plus. So any substance that is eating H plus, accepting H plus is base. But in my body, abundant base is not OH minus, it is bicarbonate. In my body, abundant base is bicarbonate. Bicarbonate actively takes up H plus and it is accepting, so it is base. Now you should get it out. Sir, here bicarbonate is binding with H plus. Ultimately an acid is formed. Why are you calling it as base? See here students, in chemistry H plus is considered as a very strong acid, whereas carbonic acid is considered as a weak acid. Because bicarbonate is binding with strong acid and making it weak acid, the acidity of the solution has been reduced. So the base work has been done. So anything that reduces acidity is automatically base. So in your body, something which eats H plus is bicarbonate. So bicarbonate is the major acceptor of H plus in the body. So automatically it will become the base. Now because of some disease, if bicarbonate increases in your body, what will happen? It will eat away all the free H plus. Whenever free H plus are reduced, so whenever H plus is reduced, automatically pH will increase. Anywhere increase in pH is referred to as alkalosis, and this is due to bicarbonate. So it should be referred to as metabolic alkalosis. Now in your body, because of some disease, bicarbonate has significantly reduced. When bicarbonate is reduced, there is nothing eating those H plus. Automatically there will be lot of H plus in your body. Whenever H plus increases, pH reduces. Anywhere reduce in pH is acidosis. This is due to bicarbonate. So it should be called as metabolic acidosis. In very simple words, bicarbonate gain is metabolic alkalosis, whereas bicarbonate loss is metabolic acidosis. Now with this background, can you tell me the relationship between pH and bicarbonate? See here, bicarbonate increase, pH has increased. Bicarbonate decrease, pH has decreased. So it must be a direct relation. So pH is directly related to bicarbonate. Now merging these two equations, can I write a single equation like this? pH is directly proportional to bicarbonate by CO2. Now this is the basic relationship between pH, bicarbonate and CO2 in your body. But this is not a standard mathematical equation. So why is this not a standard mathematical equation? Because a standard mathematical equation should have equal to, not proportionality. Now what I am going to do is, I am going to remove that proportionality and I am going to add equal to by adding some constant values. Now that equation, which will tell you the relationship between pH, bicarbonate and CO2, it is the famous Henderson-Hasselbalch equation. This is the primary relation. pH is proportional to bicarbonate by CO2. Now modifying this equation, pH is equal to 6.1 plus log of bicarbonate by PaCO2, bicarbonate by PaCO2 into 0.03. Just like in mathematics, you have a plus b whole square is equal to a square plus b square plus 2ab. This is such basic equation in ABG. Now let us see what are all the normal values. pH 7.35 to 7.45. PaCO2 will be 35 to 40 mmHg. This is the normal range. Bicarbonate 22 to 26 milliequivalents. And also you will have another value in ABG, arterial oxygen 80 to 100 mmHg. But for ABG analysis, most important will be pH, PaCO2 and bicarbonate, because these three values are primarily present in this Henderson-Hasselbalch equation. Now in this present lecture, students, any pH less than 7.35, I will consider it as acidosis. Any pH more than 7.45, we will take it as alkalosis, and normal CO2 value I will take it as 40. Bicarbonate I will take it as 26. I am taking the upper limit value. Normal CO2 as 40, normal bicarbonate as 26. Now I'll give you some examples. Tell me what is happening in this patient. Now I am standing in this room and I have suddenly stopped respiration. So what is going to happen when somebody stops respiration? What will automatically increase in their body? CO2 will increase. If CO2 increases, pH will reduce. Anywhere reduction in pH is called as acidosis. Anywhere reduction in pH is called as acidosis. This is due to CO2. So it is called as respiratory acidosis. Now there is another patient who is running for 2 kilometers and he is hyperventilating. Whenever somebody hyperventilates, what is the gas going out in excess? It is CO2. If CO2 reduced in the body, automatically pH will increase. Anywhere increase in pH is alkalosis. This is due to CO2, so it is respiratory alkalosis. So in very simple words, CO2 retention is respiratory acidosis. CO2 washout will be respiratory alkalosis. Now suppose there is a patient with diabetic ketoacidosis. Due to accumulation of keto acids, his bicarbonate has decreased. So whenever bicarbonate decreases, pH will also decrease. Anywhere decrease in pH is acidosis. This is due to bicarbonate. So it has to be called as metabolic acidosis. Whenever there is a patient with DKA and metabolic acidosis, what will be his special pattern of breathing? Kusumal's breathing. What is this Kusumal's breathing? It is very, very rapid breathing. Why will this patient have a such rapid breathing, students? Already in his body there is metabolic acidosis. To fight against this acidosis, his respiratory system is trying to send acid-like substance called as CO2 out. By doing that very, very rapid breathing, it is trying to generate a respiratory alkalosis for that metabolic acidosis. Why is it so? Your acid-base equilibrium generally follows the principle of action-reaction. If action is acidosis, reaction given by your body will be alkalosis. If action is through metabolic, reaction will be through respiratory, and it is generally vice versa. Now why should there be a reaction happening in your body? Now suppose there is either an acidosis or alkalosis. If there is no reaction given by your body, quickly this acidosis can progress to extreme acidosis. Alkalosis can progress to extreme alkalosis. At these extremes of pH, your body's metabolism will not function. So as a defense mechanism, your body generates temporary phenomena, also called as compensatory response, to bring the pH to near normal, so that patient's body will have sufficient time for that disease to get treated. So in very simple words, if primary disorder is acidosis, how will your body fight? By generating alkalosis. If primary problem is metabolic, how will your body fight? With respiratory, and it will be vice versa. Now this temporary defense mechanism, which is bringing the pH to near normal, it is referred to as compensatory response. Write down the definition. Compensatory response is nothing but body's attempt to return the pH to near normal. Now if this is primary disorder, your body will try to fight against this primary disorder by generating a compensatory response. This is the fight 24/7 happening in your body. If primary process is the villain, your body tries to generate a hero called as compensatory response. So once again, if primary problem is increase in CO2, this is respiratory acidosis, how will your body fight? By increasing bicarbonate, metabolic alkalosis. Once again, if primary problem is increase in bicarbonate, it is called metabolic alkalosis. How will your body fight? By increasing CO2, respiratory acidosis. For acidosis, compensation will be alkalosis. For metabolic, compensation will be respiratory, and it will be vice versa. These are some reflex defense mechanisms happening normally in everybody. Now let us see with this concept what is meant by simple acid-base disorder. Simple acid-base disorder means there will be a primary disorder. There will be a primary disorder. To that, your body will generate adequate. Your body will generate adequate compensatory response. Compensatory response. Now first, let us see how to identify primary disorder. Then we will discuss about how to calculate the compensatory response. Now what are all the primary disorders that you know? So we have respiratory acidosis, write down, respiratory alkalosis. Then in metabolic also two, metabolic acidosis, metabolic alkalosis. In all of this we will see what will be the trend of pH, PaCO2, bicarbonate. So in all this, let us see what will be the trend of pH, PaCO2, bicarbonate. So once again students, I am not going to discuss anything new in this slide. Just relax for 2 minutes. Whatever you have learnt in the previous slides, I will just apply here. So I am not going to teach anything new. Okay, have you all relaxed? Now with a fresh mind, don't think in a complex manner. Nothing is complicated. Everything is connected in ABG students. Now think in a very simple manner. Very simple manner. Now to call it as acidosis, what should happen to pH? pH should be reduced students. To call it as a primary respiratory disorder, where the change should be CO2. You only tell me, what is respiratory acidosis? CO2 retention. For respiratory acidosis, what is compensation? Metabolic alkalosis. We know for respiratory it will be metabolic. For acidosis it will be alkalosis. So this is how respiratory acidosis primary behaves. Now to call it as alkalosis here, what should happen to pH? pH should increase. To call it as a primary respiratory disorder, where the change should be CO2. What is respiratory alkalosis? CO2 wash out. For respiratory alkalosis, what is compensation? Metabolic acidosis. Very simple. For respiratory, metabolic. For acidosis, it will be alkalosis, and for alkalosis it will be acidosis. So this is how primary respiratory alkalosis behaves. Then to call it as acidosis here, what should happen to pH? Reduce. To call it as a primary metabolic event, where the change should happen? Bicarbonate. What is metabolic acidosis? Bicarbonate decline. For metabolic acidosis, what is compensation? Respiratory alkalosis. The best example, diabetic ketoacidosis is metabolic acidosis, and Kussmaul's breathing is the respiratory alkalosis. Now to call it as alkalosis, what should happen to pH? Increase. To call it as a primary metabolic event, where the change should happen? Bicarbonate. So what should happen to bicarbonate? What is metabolic alkalosis? Bicarbonate gain. For metabolic alkalosis, what is compensation? Respiratory acidosis. Respiratory acidosis. So this is how simple acid-base disorders behave. To understand this better, there are three important rules. Rule number 1, students. In simple acid-base disorder, first write down rules. In simple, ABD means acid-base disorder. Always primary change and compensation, primary change and compensation will move together, Then rule number 2, in primary respiratory disorder. In primary respiratory disorder. Change in pH. Change in pH with respect to WRT means with respect to CO2 and bicarbonate in opposite direction. In opposite direction. Just write down the rules. I will tell you the logic behind this. Whereas in primary metabolic disorder, primary metabolic disorder, change in pH, change in pH with respect to CO2 and bicarbonate in same direction. Same direction. Now nothing to worry, very simple. Let's start from first rule. The first rule mentions that in simple acid-base disorder, always the primary change, compensation. Primary change and compensation will be moving together. It means if primary change is increase in CO2, compensation will be increase in bicarbonate. In the same way, if primary change is increase in bicarbonate, compensation will also be increase in CO2, and it will be vice versa. You can see here, primary change increase in bicarbonate, compensation increase in CO2. Primary change increase in CO2, compensation increase in bicarbonate, and it will be vice versa. Rule number 2. If it is a primary respiratory disorder, change in pH with respect to parameters, it is in opposite direction. Primary respiratory disorder, change in pH with respect to parameters, it is in opposite direction. Now if it is a primary metabolic disorder, change in pH with respect to parameters, it is in same direction. Now let us see the logic behind this. You only tell me, students, to call it as a primary respiratory disorder, change in pH is primarily happening due to which parameter? CO2. How is pH and CO2 related? It is inverse. It means if CO2 increases, automatically pH should decrease. If CO2 decreases, automatically pH should increase. Here the logic is, to call it as a primary respiratory disorder, change in pH is due to CO2. pH and CO2 are inversely related. So change in pH with respect to parameters will be in opposite direction, because here pH is following CO2, pH and CO2 are having inverse relation. Now coming to rule number 3. To call it as a primary metabolic disorder, change in pH is primarily due to bicarbonate. How is pH and bicarbonate related? Direct. So if bicarbonate decreases, pH should decrease. If bicarbonate increases, pH should increase. To call it as a primary metabolic disorder, change in pH is due to bicarbonate. pH and bicarbonate are directly related. So change in pH with respect to parameters will be in same direction, because here pH is following bicarbonate, pH and bicarbonate are directly related. Now even if you forget this logic, don't forget this mnemonic called as ROME, ROME. What does it mean? In primary respiratory disorder, the change will be in opposite direction, whereas in a primary metabolic disorder, the change will be in same direction. If it is respiratory, the change will be in opposite direction, pH with respect to parameters. If it is metabolic, pH with respect to parameters will be in same direction. If you do some questions, you can understand this better. Even if you don't know any ABG knowledge, just write down the parameters, draw arrow marks, 70% of the job is done. So whenever they give you any ABG parameters, first you draw arrow marks. Very simple. What is happening to pH? pH reduced, PaCO2 increased, bicarbonate increased. So when compared to normal values, this is the trend. Now what is this? Acidosis or alkalosis? Anywhere decrease in pH should be referred to as acidosis. What is primary? Change in pH with respect to parameters. It is in opposite direction. So what should be the primary? Respiratory. There ends the matter. Now next question. Just to draw arrow marks, you'll get the answer. pH is elevated, CO2 is reduced, bicarbonate is reduced. No doubt, anywhere increase in pH is called as alkalosis. Change in pH, what is primary? Change in pH with respect to parameters, it is in opposite direction. So what should be the primary? Respiratory. So you only solve next to two questions. Just to draw arrow mark, students, you will get the answer. Here pH reduced, CO2 reduced, bicarbonate reduced. Anywhere decrease in pH should be called as acidosis. So what is primary? Change in pH with respect to parameters, it is in same direction. So what should be the name? Metabolic. Then here pH increased, CO2 increased, bicarbonate increased. No doubt increase in pH is alkalosis. Change in pH with respect to parameters, it is in same direction. So what should be the name? Metabolic. So once again, going through those three rules. Let it be any disorder, acidosis or alkalosis, respiratory or metabolic. Always primary change, compensation. Primary change, compensation. They will be moving together. Rule number 2. If it is a primary respiratory disorder, change in pH with respect to parameters, it will be in opposite direction. If it is primary metabolic disorder, rule number 3, change in pH with respect to parameters will be in same direction. Now what was the definition of simple acid base disorder? There will be a primary disorder. For that your body will give compensatory response. This is how you should identify primary disorder. Now for calculation of compensation, each and every disorder is having a special formula. If you apply the formula, you can calculate compensatory response. So first let us see compensation for respiratory acidosis. We have acute respiratory acidosis, chronic respiratory acidosis. Again, compensation for respiratory alkalosis, acute respiratory alkalosis, chronic respiratory alkalosis. So simple rule of thumb, for primary respiratory disorder, you should calculate metabolic compensation. For primary metabolic disorder, we calculate respiratory compensation. Let us see the standard formula. In acute respiratory acidosis, for every 10 mm Hg increase in CO2, bicarbonate should increase by. Now this is an acute event. Still your kidney is not ready. So it will only increase by 1 milli equivalent. Now chronic respiratory acidosis, for every 10 mm Hg increase in CO2. Now this is a chronic disorder. Now your kidneys have understood how to tackle this disorder. So it is going to retain more bicarbonate, 4 milli equivalents. How to exactly say whether it is acute or chronic? By patient's clinical history. Now say for example, this patient is having foreign body aspiration. Is it acute or chronic? Acute. Ongoing neuromuscular disorder. It is chronic. Now how to calculate compensation? Say for example, because of an acute disorder, CO2 value from normal value of 40, it has increased it to 60. To call it as adequate compensation, bicarbonate should increase from 26 to how much? For 10, it is 1. For 20, it will be 2. 26 plus 2, 28. If it reaches to 28, it is considered as adequate compensatory response. Now because of some chronic disorder, once again see here, CO2 has increased from normal value of 40 to 60 by 20. To call it as adequate compensation, bicarbonate should increase from normal value of 26 to how much? For 10, it is 4. For 20, it will be 8. 26 plus 8, 34. So like this, you have to calculate. Then, for respiratory alkalosis, because they are derived from various graphs, the formulas are slightly different. For every 10 mm Hg decrease in CO2, bicarbonate decreases by 2 milli equivalents. Slightly different formula. For every 10 mm Hg in chronic, CO2, bicarbonate decreases by 4 milli equivalent. So now if you do a question, you will understand this better. There was a patient with chronic neuromuscular disorder. NMD means neuromuscular disorder. His pH was 7.33. His PaCO2 was 60. Bicarbonate was 34. Quickly tell me what is the primary acid base disorder and also calculate compensation. Just to draw arrow marks. Reduced, increase when compared to normal, increase. Anywhere decrease in pH should be called as acidosis. What is primary? Change in pH with respect to parameters. It is in opposite direction. So primary is respiratory. Is it acute or chronic? Chronic. Now in chronic, how to calculate this compensation? In this patient, CO2 has increased from normal value of 40 to 60. It has increased by 20. To call it as adequate compensation, bicarbonate should increase from normal value of 26 to how much? For 10, it is 4. For 20, it will be 8. 26 plus 8, 34. Given bicarbonate is 34, expected is also 34. It is correlating. So it is adequate compensatory response. So it is chronic respiratory acidosis with compensatory metabolic alkalosis. This is the complete name, but I am very lazy to write this big name. It is also written as, is it acute or chronic? Chronic. Is it adequately compensated, yes or no? Yes. And if you want to write one disorder, it should always be the primary disorder, or it can be just written as chronic compensated respiratory acidosis. So in very simple words, in a question, if you identify primary respiratory acidosis, you should calculate compensation with one of this formula. If you identify a primary respiratory alkalosis, you should calculate compensation with one of this formula. So either you can write it as chronic respiratory acidosis with compensatory metabolic alkalosis, or is it adequately compensated? Yes, chronic compensated. And if you want to write one disorder, it should always be the primary disorder. This is how you should calculate compensation for primary respiratory disorder. Let us see how to calculate compensation for primary metabolic disorders. Again, there are two metabolic disorders, metabolic acidosis, metabolic alkalosis. For metabolic acidosis, there is a special formula. The name is Winter's formula. According to this, expected CO2 is equal to 1.5 into bicarbonate, 1.5 into bicarbonate plus 8 plus or minus 2. Whereas for metabolic alkalosis, it is a very simple formula. Expected CO2 is equal to bicarbonate plus 15. If you do some questions, you can understand. Now there was a patient with pH 7.29, PaCO2 22, bicarbonate is 10. Identify the primary disorder and also calculate compensation. Very simple. Draw arrow marks. Reduced, reduced, reduced. Anywhere decrease in pH is called as acidosis. What is primary? The change is in same direction. So what should be the name? Metabolic. So whenever you identify primary metabolic acidosis, you should calculate respiratory compensation. How to calculate? Utilize this formula. Expected CO2 is equal to 1.5. How much is bicarbonate here? 10 plus 8 plus or minus 2. So it will be 15 plus 8 plus or minus 2. 23 plus or minus 2. So it has to be in the range of 21 to 25 mmHg. How much is given CO2? 22. Expected, it is correlating. So it is adequate compensation. So the full name, metabolic acidosis with compensatory respiratory alkalosis. Once again, in very simple words, students, if you identify a primary metabolic acidosis, calculate compensation with this special formula. If you identify a primary metabolic alkalosis, you can calculate compensation with this simple formula. Now whatever we have learnt up to now, let us put it into the famous ABG algorithm. Now before going through the ABG parameters, most important is patient's clinical history. Why is it so? Because ultimately you are not going to treat the numbers, you are going to treat the disease or disorder responsible for the numbers. I'll give you one clinical relevant example. Now there is one patient with diabetic ketoacidosis, metabolic acidosis. Another patient with renal failure, metabolic acidosis. So in both of them there is metabolic acidosis only, but the treatment is completely different. If it is DKA, the treatment will be insulin plus fluid. If it is renal failure, it is no fluid. See here, even though both are metabolic acidosis, the treatment is completely different. That's why before going through ABG parameters, first thing is always going through clinical history. Without proper clinical history, the parameters are not that relevant. So first thing in ABG algorithm, go through the clinical history. The algorithm, go through the clinical history. After going through the clinical history, now look at the ABG. Now after looking the ABG, first step, see the pH. By seeing the pH, you should be able to at least tell, are you dealing with acidosis or alkalosis? Then next step is, what is the primary disorder? By seeing the direction of change, if it is in opposite direction, it is primary respiratory disorder. If it is in same direction, it will be primary metabolic disorder. So disorder here means it can be either acidosis or alkalosis. Third step, calculation of compensation. So if it is a primary respiratory disorder, what compensation you should calculate? Metabolic. If it is a primary metabolic disorder, what compensation you should calculate? Respiratory. For each of this disorder, there is a special formula. So apply that formula and compare. In majority of the situation, given bicarbonate in the question will be correlating with expected bicarbonate. On this side also, given CO2 in the question will be correlating with expected CO2. So if given and expected are correlating, what does it mean? Adequate compensation. What was the definition of simple acid-base disorder? A primary disorder and adequate compensatory response. This can be just written in easy words as simple acid-base disorder. But uncommonly, in few situations, you can get a relationship like this. Given bicarbonate not correlating with expected bicarbonate. On this side also, given CO2 not correlating with expected CO2. So see here, if given and expected are correlating, it is appropriate or adequate compensation. If given and expected are not correlating, it is inappropriate compensation. So previously we were using the terms partial compensation, decompensation, overcompensation. Now according to New Harrison, whenever there is a relevant history, you should not use all those old terms. You should just call it as mixed acid-base disorder. So in very easy words, if given and expected are correlating, it is simple. If they are not correlating, it is inappropriate compensation. Whenever there is a relevant history, now what is the special name given to it? Mixed acid-base disorder. Now you no need to worry about this mixed acid-base disorders. When I discuss all the individual acid-base disorders, I will discuss this mixed acid-base disorder in detail. Then next step after compensation, it is calculation of anion gap Ag in blood. Anion gap, also written as Ag in blood. Now if at all there is high anion gap, there is an advanced step. So this you need to know, students. Anion gap is our next topic of discussion. If there is high anion gap, there is an advanced step. What is that advanced step? One should compare change in anion gap, also written as delta anion gap, and change in bicarbonate, also written as delta bicarbonate. So this is an advanced step. If at all there is high anion gap, you should also see the relevance of this relation. Compare change in anion gap and change in bicarbonate. Then the last step, put it together with clinical history and give your final impression. So this is the most simplified algorithm of ABG. After going through clinical history, see the pH. Are you dealing with acidosis or alkalosis? By applying Rome, is it respiratory or metabolic? And with the help of formulas, whether compensation, adequate compensation, inappropriate. Adequate is simple, inappropriate compensation is mixed. Then calculation of anion gap in blood, and put it together with clinical history and give your final impression. Now let us discuss what is this concept of anion gap in blood, and we will also see the metabolic acidosis in detail. So write down concept of anion gap in blood and also metabolic acidosis. Let us see the concept of anion gap in blood and metabolic acidosis. So in my body there are two compartments, a positive compartment, a negative compartment. Always to maintain electron neutrality, the total number of positives will be equal to total number of negatives. But there are few positives that I routinely measure bedside. What are the positives that you routinely measure bedside? Sodium, potassium. There are few negatives that you routinely measure bedside, that is chloride, bicarbonate. Always between measured positives and measured negatives, there is a significant gap called as anion gap. So anion gap Ag is actually the difference between measured positives and measured negatives. Now let us try to understand this. Let us say this is the negative compartment. It is having two parts. Measured part that we routinely measure bedside, and other is unmeasured part that we routinely don't measure. Consider this bottle filled with water. This bottle filled with water. So it is it is negative compartment. So whatever you see here, this is measured part. This everything which is empty is unmeasured part. Now because of some disease, students, if this measured part is decreasing, automatically unmeasured part will increase. In the same way, because of some disease, if unmeasured part is increasing, automatically measured part will decrease. So just like in this bottle, always the measured part and unmeasured part will mutually adjust to maintain the total volume of this given compartment. Now if you see in the measured positives, we have sodium. What is the normal value of sodium? It is 135 to 145. What is normal value of potassium? 3.5 to 5.5. When compared to sodium value, potassium value is very less. So recently for calculation of anion gap, we stopped taking potassium. So the new formula for anion gap is equal to sodium minus chloride plus bicarbonate. If you use this formula and calculate anion gap, normal anion gap will be in the range of 8 to 12 milli equivalents, or 10 plus or minus 2 milli equivalents. 10 is considered as the reference value. Now for all practical purposes, in the exam if they ask you anion gap, you should use this new formula only. Sodium minus chloride plus bicarbonate. Now this is something routinely happening in all of our bodies. In all of our bodies, between measured positives and measured negatives, there is a significant gap. So what is that significant gap referred to as anion gap? Now let us see its relevance in metabolic acidosis. We have high anion gap metabolic acidosis. Again the same compartments, a positive compartment, negative compartment. Positive compartment predominantly made up of sodium. Negative compartment predominantly made up of chloride bicarbonate. In between these two, there is a significant gap. It is anion gap. Now for development of high anion gap metabolic acidosis, primary event is addition of acid to body. Because of some disorder, excess acid is added to the body. So let it be any acid in the universe. What is the property of acid? To give lots and lots of H+. Along with H+, it gives its corresponding acid anion. Say for example, the acid is H2SO4. How will it divide? H plus HSO4 minus. In the same way, the acid is HNO3. How will it divide? H plus NO3 minus. So let it be any acid in the universe. It has to give H plus and acid anion. Lactic acid, how it will divide? H plus lactate. Formic acid, how it will divide? H plus formate. Salicylic acid, H plus salicylate. Now whenever there is lots and lots of H plus, what is the most important buffer for H plus in your body? Bicarbonate. This bicarbonate will be consumed as buffer. This is the first event, because bicarbonate is reducing. This is metabolic acidosis. Now this acid anion is negatively charged. It will automatically start adding up to the unmeasured compartment. This is event number 2. Because of these two events, now the anion gap will be persistently high. Previously this was the anion gap. Now the anion gap has increased. Now after addition of acid, there are three important events. Event number 1, bicarbonate consumed as buffer, that was responsible for metabolic acidosis. This acid anion being added to the unmeasured compartment. Because of these two, what has happened to the anion gap? Anion gap has become persistently high. So there is metabolic acidosis and it is associated with high anion gap. So it was called as high anion gap metabolic acidosis. So write down the mechanism, you will understand better. The rise in anion gap, students. The rise in anion gap is due to simultaneous. The rise in anion gap is due to simultaneous decrease in bicarbonate and increase in acid anion. So what is this acid anion? It is nothing but unmeasured anion. So what does it mean? For anion gap to increase, simultaneously there is decrease in bicarbonate and increased accumulation of acid anion. But if you see an ABG report, you will be only seeing rise in anion gap, decrease in bicarbonate, because unmeasured anion is not generally measured. That's why there is a relation. Studies have shown that this rise in anion gap and decrease in bicarbonate were mutually exclusive. For there is a relation. For every 1 milli equivalent increase in anion gap, bicarbonate should decrease by 1 milli equivalent. This is another important relation that you should know. It means if anion gap has increased by 1 milli equivalent, bicarbonate will also decrease by 1 milli equivalent. Now to understand this high anion gap metabolic acidosis, I have made a simple video. So let this be equilibrium. So let this be sodium chloride bicarbonate, and it between these two there is anion gap. Now what is going to happen after addition of acid? Now after addition of acid, you go through these three events. Event number 1, bicarbonate consumed as buffer, acid anion added to the unmeasured compartment, both put together has significantly increased the anion gap. Once again see here, after addition of acid, three important events: bicarbonate consumed as buffer, acid anion being added here. Because of these two, anion gap has significantly increased. Now coming to the causes of high anion gap metabolic acidosis. It is nothing but addition of acids. How will acid be added? Number 1, ketoacidosis, lactic acidosis, excess production of acids in your body. Number 3, when will these acids produce not go out from your body? Renal failure. Number 4, toxins or drugs. You must be knowing any alcohol can get converted into aldehyde, aldehyde to acid. Ethanol can get converted to acid. Methanol can get converted into formic acid, and ethylene glycol can get converted into oxalic acid, and any drug which is acid, it is nothing but salicylic acid. So the causes of high anion gap metabolic acidosis, number 1 group will be toxins or drugs. Toxins or drugs. Number 2, ketoacidosis. ketoacidosis. It can be a part of diabetic ketoacidosis, starvation ketoacidosis, or alcoholic ketoacidosis. Number 3, it is lactic acidosis. Lactic acidosis. Number 4, when will these acids form not go out from your body? Renal failure. Let us start with toxins or drugs. Toxins such as methanol. Methanol can be converted into acid, formic acid. Then paraldehyde. This aldehyde can also be later converted into acid. Third, ethylene glycol poisoning. What is the trade name of ethylene glycol? It is antifreeze. So this ethylene glycol, when somebody takes, it can get converted into oxalic acid in the body, and this oxalic acid can be released in the urine. So these patients can have oxaluria. And a drug which is acid, aspirin. It is nothing but salicylic acid. Now coming to lactic acidosis, it is further divided into type A lactic acidosis. It is the regular lactic acidosis, and we have the unusual lactic acidosis, that is type B lactic acidosis. So when will lactic acidosis generally happen? As a part of anaerobic metabolism, either decreased perfusion or oxygenation. So type A is classical lactic acidosis. So the perfusion is reduced or oxygenation is improved. Whereas type B lactic acidosis, here in spite of normal perfusion also, there will be lactic acidosis. First let us see classical lactic acidosis. The causes are shock. Then it can be due to anemia. It can be due to carbon monoxide poisoning. Now why in shock? What actually carries oxygen to the tissues? Blood. In shock there is no perfusion reaching the tissues, anaerobic metabolism will take place. And what exactly in the blood? Hemoglobin. In anemia there is less hemoglobin. So hemoglobin is less means less oxygen will be carried to the tissues. In carbon monoxide poisoning, all the hemoglobin will be bound tightly by carbon monoxide. There will be no place for oxygen to sit. Because oxygen is unable to bind to hemoglobin, oxygen cannot be carried to the tissues. Now coming to type B lactic acidosis, it is further divided into a systemic cause. So what are the systems dealing with lactic acidosis? First you need to know. Number 1 system is your liver. Liver breaks down excess lactic acid. So whenever there is liver failure, lactic acid accumulates. Number 2 system is your kidney. Kidney excretes excess lactic acid. Whenever there is kidney damage, kidney failure, lactic acid will not be excreted, it accumulates. Then it can be due to various drugs. Drugs such as metformin, isoniazid, zidovudine. These drugs can involve in lactic acid pathways resulting in its accumulation. These drugs can involve in lactic acid pathways, resulting in accumulation of lactic acid. So whenever you come across high anion gap metabolic acidosis, think in terms of either toxins or drugs, possibility of ketoacidosis, possibility of lactic acidosis, possibility of renal failure. Very, very important clinical concept. High anion gap with relevant history should always be taken significant. Generally, in the emergency department, high anion gap will never be incidental. It is generally pathological, suggestive of some high anion gap metabolic acidosis. Now say for example, there is a patient with diabetes. On evaluation there is high anion gap. What you should immediately suspect? Diabetic ketoacidosis. Now there was a patient with pre-existing renal disease. Now on evaluation his anion gap was high. Now what you should suspect? You should suspect possibility of renal failure. So that is why high anion gap with relevant history should always be taken significant. And in most situations, presence of high anion gap is actually synonymous with high anion gap metabolic acidosis. So this is one of the clinical point that you should know. Next, coming to normal anion gap metabolic acidosis. Again, the same compartments, a positive compartment made up of sodium, a negative compartment made up of chloride bicarbonate. In between these two, there is a significant gap called as anion gap. Now for development of normal anion gap metabolic acidosis, it is not due to addition of acid. Because of some disease, there will be loss of bicarbonate from your body. Because bicarbonate is lost, this phenomena is called as metabolic acidosis. For whatever bicarbonate is lost, your kidneys will take back equal amounts of chloride in return, because chloride is coming back in excess. The volume of this compartment, chloride and bicarbonate, remains same. So anion gap will also not change. So there is metabolic acidosis, but no change in anion gap. So it is called as normal anion gap metabolic acidosis, because chloride has come back in excess. In some books, this phenomena is also called as hyperchloremic metabolic acidosis, but always the best name is normal anion gap metabolic acidosis. Now what are the situations where bicarbonate can be lost from your body? So very common situation, everybody must have experienced diarrhea. You must be knowing your lower GIT is pooled with bicarbonate, and the source of bicarbonate is from the pancreas. In diarrhea, there is loss of lower GI secretions, lower GI secretions rich in bicarbonate. Because bicarbonate is lost from the body, what will the body develop? Metabolic acidosis. Another association, for completion's sake, what happens in vomiting students? So in vomiting, there is loss of upper GI secretions. What is upper GI secretion rich in? Acid. Because acid is lost, what will this patient develop ultimately? Metabolic alkalosis. Metabolic alkalosis. So in very simple words, diarrhea ultimately causes metabolic acidosis, whereas vomiting generally causes metabolic alkalosis. Then next thing that you need to know is what happens in hyperaldosteronism, what can happen in hypoaldosteronism. So what happens in hypoaldosteronism. Now first of all tell me, where is this aldosterone essential? It is actually essential in the collecting duct for reabsorption of sodium and water. So for whatever sodium is coming inside, what will go out from your body? K plus and H plus. In hyperaldosteronism, there is excess sodium reabsorption. So for whatever extra sodium is coming into your body, so what will be lost into the urine? Lot of sodium is coming. So in the urine, there will be excess loss of K plus and H plus. Because K plus is lost from the body, body will develop hypokalemia. H plus is also lost, body will develop metabolic acidosis. So write down, in hyperaldosteronism, there is excess sodium reabsorption. There is excess sodium reabsorption that results in loss of H plus and K plus from body, because H plus and K plus are lost. What will body develop? Metabolic alkalosis with hypokalemia. So opposite of hyperaldosteronism is hypoaldosteronism. So here what will happen? In hypoaldosteronism, this sodium is not at all reabsorbed. So what will happen? There is decreased sodium reabsorption. There is decreased sodium reabsorption because aldosterone is not working, sodium is not reabsorbed. That results in retention of H plus and K plus in body, because H plus and K plus are staying in the body. What will body develop? Increased H plus is metabolic acidosis. Increased K plus is nothing but hyperkalemia. So in very simple words, students, hyperaldosteronism will cause metabolic alkalosis, hypokalemia, whereas hypoaldosteronism is responsible for metabolic acidosis, hyperkalemia. Now you should get a valid doubt. Why loss of H plus is metabolic alkalosis, gain in H plus is metabolic acidosis? So it is very simple. In your body, H plus and K plus will H plus and bicarbonate will be in equilibrium. So there will be some free H plus and bicarbonate circulating and maintaining the pH. Now because of some disease, if H plus is reducing, H plus is lost from the body, automatically free bicarbonate will increase. Now because of some disease, if H plus has increased in your body, all the free bicarbonate will bind to this H plus. So anywhere reduce in free bicarbonate is nothing but metabolic acidosis. In other words, you know that H plus is a very strong acid. So gain in H plus is metabolic acidosis. Loss of H plus will be metabolic alkalosis. So once again students, in diarrhea there will be metabolic acidosis. In vomiting there will be metabolic alkalosis. In hyperaldosteronism it is metabolic alkalosis hypokalemia. In hypoaldosteronism it is metabolic acidosis with hyperkalemia. Now with this background, let us see what are the causes of normal anion gap metabolic acidosis in detail. So this can be classified into a GIT cause and other is renal cause. So this renal cause in detail will be discussed in your nephrology, but what is required for ABG I will let you know here. Now the primary mechanism of most of the GI cause will be loss of bicarbonate rich secretions from the body. Loss of bicarbonate rich secretions. So what are the conditions responsible? It can be due to diarrhea. You know what is diarrhea? Loss of lower GI secretions rich in bicarbonate. Then enterocutaneous fistula. So what is meant by entero? Entero means intestine, cutaneous means skin, fistula means opening. So there is an opening from the intestine to outside. Through that what will be lost? Intestine secretions rich in bicarbonate can be lost. And third is a pancreatic fistula. So what is the source of bicarbonate to your lower GIT? Pancreas. Now from the pancreas there is a connection to outside. Through that connection what will be lost? Pancreatic secretions rich in bicarbonate can be lost. Next is a surgery called as ureterosigmoidostomy. This is a slightly different mechanism. What is meant by ureterosigmoidostomy? Bringing the ureters and connecting it to sigmoid colon. So when this surgery is actually done, whenever there is bladder carcinoma, now ureters cannot go into bladder. They will be diverted into sigmoid colon. Now what does ureters generally contain? It contains chloride. Now suddenly into the intestine through urine, lot of chloride will come into the intestine. Now your intestine likes chloride very well. So for whatever chloride is taken in, your intestine will take up all this chloride. So for whatever chloride is taken in, a negative called as bicarbonate, a negative called as bicarbonate will be lost in patient's excreta. Because bicarbonate is lost, it is metabolic acidosis. Because chloride has been excessively reabsorbed, there will be no change in anion gap. Try to understand this simple concept. In ureterosigmoidostomy, ureters are connected to the intestine. Now urine generally contains lot of chloride. Now suddenly lot of chloride is coming into the intestine. Your intestine likes chloride very much. It feels that this fellow has taken chloride rich diet and it reabsorbs all the chloride. For whatever chloride is being reabsorbed, a negative called as bicarbonate will be thrown out from the body in patient's excreta. Because bicarbonate is lost, it is metabolic acidosis, and chloride has been reabsorbed, the anion gap will be normal. Now coming to renal causes. So first group will be renal tubular acidosis, that is RTA. Next will be drugs. So in RTA we have type 1 and type 2. Why I am writing these together? Because they have similar presentation of metabolic acidosis with hypokalemia, whereas type 4 RTA, most common, it is associated with metabolic acidosis with hyperkalemia. So the mechanisms of type 1, type 2, type 4, type 3 is not clearly defined, is an extensive topic of discussion in your nephrology. Then coming to drugs, we have ACE inhibitors, aldosterone antagonist, then carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors. Now first of all, whenever I give ACE inhibitors, what will not work in my body or what will not be formed in my body? Aldosterone. Whenever I give aldosterone antagonist, what will not work in my body? Aldosterone. So these two drugs create a situation similar to hypoaldosteronism. Now what is the function of aldosterone? To take sodium inside the body and to throw out K plus and H plus. Because aldosterone is not acting properly, sodium will not come into the body. So there will be retention of H plus and K plus in the body. If a H plus increases, there will be metabolic acidosis. If K plus increases, there will be hyperkalemia. So this is what we have discussed previously. So in hypoaldosteronism, what is the end result, students? In hypoaldosteronism, metabolic acidosis, hyperkalemia. So what is the side effect of ACE inhibitors and aldosterone antagonist? It will be metabolic acidosis, hyperkalemia. Then coming to carbonic anhydrase enzyme, where is it actually helpful? Carbonic anhydrase enzyme is required for reabsorption of bicarbonate in proximal convoluted tubule. Now if you inhibit this enzyme by drugs such as acetazolamide, carbonic anhydrase inhibitor is given, there will be no reabsorption of bicarbonate from PCT. There will be decreased reabsorption of bicarbonate from PCT, because bicarbonate is not getting reabsorbed, it will be lost in the urine. Anywhere loss of bicarbonate from the body is metabolic acidosis. So in this table we have seen what are the GIT causes and renal causes responsible for normal anion gap metabolic acidosis. Next, let us see metabolic alkalosis. For metabolic alkalosis, actually there are two types of classification. One is based on mechanism and two based on our convenience in emergency department, we have divided it into saline responsive and unresponsive. So write down metabolic alkalosis. The first classification is based on mechanism. The second classification is based on response to saline. Now first let us see the first classification based on mechanism. Metabolic alkalosis is divided into three categories. Category 1, metabolic alkalosis happening due to persistent hypovolemia. Metabolic alkalosis persisting due to continuous hypovolemia. Then category 2, this is due to some unnecessary aldosterone excess. What is this unnecessary aldosterone excess? I will describe later. Then we have category 3. This is due to some primary genetic defects of renal tubules. Primary genetic defects of renal tubules, which includes Bartter syndrome, Gitelman syndrome, Liddle syndrome. In all these genetic defects, the end result will be metabolic alkalosis. So these three, Bartter syndrome, Gitelman syndrome, Liddle syndrome, they are extensive topics of discussion in your nephrology. There you will understand why in these three ultimately there is metabolic alkalosis. Now let us see category 1 and category 2. Category 1, conditions such as vomiting. If a patient does by himself, it is vomiting. If you put a Ryle's tube in the stomach and aspirate, it is the same result. And also long-standing diuretic use. In all this situation, ultimately there will be persisting volume loss. So whenever there is significant volume loss, what is the system getting activated in your body? Renin, angiotensin, aldosterone system. So if aldosterone is excessively functioning, what is the end result? There will be metabolic alkalosis. Because of continuous or persisting volume loss, there will be activation of renin, angiotensin, aldosterone system that can be responsible for metabolic alkalosis. Then coming to category 2, unnecessary aldosterone excess such as primary hyperaldosteronism, renin secreting tumor, then we also have Cushing's syndrome. In all this, the end result will be metabolic alkalosis. Now you know what is primary hyperaldosteronism. 24/7 unnecessarily aldosterone is produced in your body. So there will be continuation of metabolic alkalosis. If renin increases, automatically what will increase? Aldosterone. So increased aldosterone activity will automatically cause metabolic alkalosis. Now this Cushing syndrome is not mineralocorticoid excess. It is glucocorticoid excess. But end result is metabolic alkalosis. What is the reason? even these glucocorticoids will have some amount of mineralocorticoid activity. So in all this, the end result is metabolic alkalosis. And point to remember, in this, along with metabolic alkalosis, these patients will have hypertension. So what is the logic behind this? Normally, when is aldosterone necessary for your body? Whenever there is some volume loss. Whenever there is some volume loss, aldosterone acts excessively, tries to bring the volume to near normal. So once the volume becomes near normal, by negative feedback mechanism, automatically aldosterone activity will be cut off. Now here in category 2, there is no volume loss at all. The aldosterone activity is unnecessarily happening due to some primary pathology. Unnecessarily 24/7 irrespective of volume loss, there is aldosterone activity. If unnecessarily aldosterone is acting on your kidney, what will happen? Continuously there will be lot of sodium and water reabsorption. Whenever lot of sodium and water is reabsorbed, what will happen to the volume status of the patient? Extracellular fluid volume expansion. When there is lot of sodium and water, what will happen to the blood pressure of the patient? It will increase. Whereas in category 1, this is happening due to volume loss. Now if aldosterone is acting excessively, and when the BP comes back to near normal, automatically by negative feedback mechanism, aldosterone activity will stop. So there is no scope of hypertension here. But whatever aldosterone activity is happening in category 2, it is unnecessary. Because of unnecessary aldosterone activity, lot of sodium and water is reabsorbed, resulting in hypertension. So it is just like if an hungry individual is eating food, once his hunger subsides, he will stop eating. So he is not going to gain excess weight. But if a person is eating 24/7 unnecessarily for time pass, he is not hungry, eating itself is his job. So what will happen to that patient? He is going to become obese. So in the same way, category 1 is just like hungry individual eating. Once his hunger is satisfied, he will stop eating. So he is not going to gain extra weight. So he is not going to gain volume excess. Whereas category 2 is an individual eating 24/7 for time pass. He is not at all hungry, but he is keeping on eating unnecessarily. If he keeps on eating, what will happen to his weight? He will increase. If he keeps on using aldosterone, there will be volume excess resulting in hypertension. So there is another parameter which will differentiate category 1 and category 2. Studies have shown that in category 1, urinary chloride level was found to be less than 20 milliequivalents. Whereas in category 2, urinary chloride level was found to be more than 20 milliequivalents. So what is the logic behind this? Again, very simple, students. Category 1 is generally due to hypovolemia. You only tell me, whenever volume is less in your body, what will your good kidneys try to do? It will try to retain volume. How will it retain volume or water? With its best friend called as salt. So what does salt contain, student? What does salt contain, students? Chloride. Because salt is kept in the body. Chloride is kept in the body. Within the urine, chloride will be less. So in category 1, urinary chloride will be less. Whereas in category 2, already patient is in volume excess, hypertension. If already there is extra volume in your body, is there any compulsion for kidney to retain salt? No. So within the urine, chloride will be lost usually. So urinary chloride will be more than 20 milliequivalents. So simple logic here is, category 1 is due to hypovolemia. When there is less volume, your kidneys will try to retain water with help of salt. What does salt contain? Chloride. Because chloride is coming into the body. Within the urine, chloride will be less. Whereas category 2, Already volume excess, hypertension. Is there any compulsion for your kidney to retain chloride? No. So within the urine, chloride will be lost usually. So urinary chloride will be more than 20 milli equivalents. This is the first type of classification based on mechanism. Now coming to the second type of classification in the emergency department, we divide metabolic alkalosis into saline responsive, where metabolic alkalosis will be corrected by giving saline. Other is saline unresponsive. So where even if you give saline, there will be no significant metabolic alkalosis may not be corrected. Now with this background, out of these, which can be saline responsive, your answer should be category 1. Because why category 1 is happening? Due to volume loss. Now if you give saline and correct this volume, the trigger to renin-angiotensin aldosterone system is removed. So the metabolic alkalosis will gradually resolve. Whereas saline unresponsive is category 2 and category 3. So why category 2? In category 2, already the patient is in hypertension. Already when somebody is in hypertension, if you dump extra saline, this fellow will develop fluid overload and die of cardiac failure. So there is no point in giving saline in category 2. Now category 3. This category 3, it is due to some primary genetic defects of renal tubules. You only tell me, just by giving a point of saline, will all these genetic defects be corrected immediately? No. Even if you give saline, because of this persistent genetic defects, the metabolic alkalosis will be persisting. So in very simple words, in the emergency department, if you find it as saline responsive, just to give saline, save the life of the patient, the story is over. But if you think it in terms of saline unresponsive, you have to evaluate for the precise cause and treat it appropriately. So the first is based on mechanism, the second is based on response to saline in the emergency department for our convenience. Now if you do some questions, you can understand this better. There was a 25-year-old male, history of vomiting, brought to the emergency department. On examination, his BP is low. Now the vomiting has completely subsided, but ABG is showing severe metabolic alkalosis. How to treat metabolic alkalosis, they are asking. First understand, why did metabolic alkalosis happen? So what was the initiating event? Initiating event should be the patient's vomiting. Now the vomiting has subsided completely, but still there is severe metabolic alkalosis. So there must be a persisting event. So what is this persisting event? It must be volume loss that must have triggered renin-angiotensin aldosterone system, and that must be responsible precisely for persistence of metabolic alkalosis. How can I say that there is volume loss? Patient's BP is low. Now they are asking you, how will you correct the metabolic alkalosis and save the life of the patient? Your answer should be IV normal saline. Now if you give normal saline to the patient, you are going to correct the volume. So the trigger to renin-angiotensin aldosterone system is removed. Gradually metabolic alkalosis will resolve. So this is a classical case of saline responsive metabolic alkalosis. Then next topic is respiratory acidosis. Already I have discussed in detail regarding respiratory acidosis. Where is it actually? What is respiratory acidosis? CO2 retention. What is CO2 retention, also called as hypercapnia? Where did we discuss hypercapnia previously? Type 2 respiratory failure. So respiratory acidosis is nothing but equal to type 2 respiratory failure. Already we have discussed the mechanisms and various causes. So write down respiratory acidosis it is similar to type 2 respiratory failure. Then coming to respiratory alkalosis. Actually, chronic respiratory alkalosis is considered as most common acid base abnormality. Is considered as most common acid base abnormality in critically ill patient. So why is it so? Once you see the causes of respiratory alkalosis, you will understand. Number 1, pain, panic, psychogenic, progesterone. Peculiarly, all these are female predominant. In pain, people will hyperventilate. In panic, people will hyperventilate. Few young females will be hyperventilating for no reason. That is called as psychogenic hyperventilation. And progesterone has the capacity to directly stimulate respiratory center. Then second group, sepsis, cirrhosis. These conditions produce toxins in your body. These accumulated toxins can also stimulate respiration. Then any disease responsible for hypoxemia can stimulate respiratory receptors. As long as your respiratory effort is intact, how will your body fight against hypoxemia? By hyperventilation. As long as your respiratory effort is intact, there will be hyperventilation. If somebody is hyperventilating, what is the gas going out in excess? CO2. Hypoxemia related hyperventilation can result in CO2 washout. Then accidental mechanical hyperventilation. So whenever you connect a patient to a mechanical ventilator, you are going to set some respiratory rate. Say for example, you have set physiological value 14 or 15 per minute. Now a new fellow has come into the ICU without knowing. He has increased the rate from 15 to 30. So accidentally you have increased the respiratory rate. So that will result in some CO2 washout. Now why chronic respiratory alkalosis is considered as most common acid base abnormality in critically ill patient? Because a critically ill patient might be in pain, might be in panic, might have sepsis, might have hypoxemia, might have been connected to a mechanical ventilator. Because all these events are frequently happening in critically ill patient, so they thought that chronic respiratory alkalosis is most common acid base abnormality in them. Then coming to a drug called as aspirin. So where did we discuss aspirin in ABG today? High anion gap metabolic acidosis. This aspirin can also directly stimulate respiratory center. By stimulating respiratory center, it can be responsible for respiratory alkalosis. But there is an exception. In very high doses, aspirin can cause respiratory depression that can result in respiratory acidosis, but nowadays this presentation is very, very rare. So previously asked question, aspirin frequently causes respiratory acidosis. Aspirin frequently causes respiratory acidosis. Is it a true statement or false statement? It is absolutely false. Aspirin frequently causes respiratory alkalosis. It causes high anion gap metabolic acidosis. So this respiratory acidosis is very, very rare nowadays, not seen in clinical practice. So with this we have seen the primary acid-base disorders. I mean the individual metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. Now coming to an important topic, that is mixed acid-base disorder. Now for mixed acid-base disorder, clinical history is very, very important. Without clinical history, it is difficult to interpret mixed acid-base disorder. So write down mixed acid-base disorder. Clinical history, very important. For your convenience, I am rewriting the ABG algorithm. After identifying it as acidosis or alkalosis, you have to identify what is the primary disorder. So it can be either primary respiratory disorder or primary metabolic disorder. Now after identifying the primary disorder, next is compensation. If it is a primary respiratory disorder, what compensation you will calculate? Metabolic disorder, we calculate respiratory compensation. In majority, you will get a situation like this, students. Given bicarbonate in the question is correlating with expected bicarbonate. On this side also, you will get a situation like this. Given CO2 is correlating with expected CO2. If given and expected are correlating, what is this adequate compensation? In very easy words, it can be written as simple acid-base disorder. Simple acid-base disorder. Whereas uncommonly, you can get a relationship like this. Given bicarbonate not correlating with expected bicarbonate. On this side also, given CO2 not correlating with expected CO2. So if given and expected are not correlating, it is mixed acid-base disorder. On this side also, it is mixed acid-base disorder. Now observe here, students. If given and expected are correlating, it is simple. If they are not correlating, it is mixed. This is what we have seen up to now. Now mathematically, if given and expected are not correlating, there can be two possibilities. Either given is very much higher than expected, or given is very much lower than expected. So when they are not correlating, we have two possibilities. Possibility 1, given bicarbonate in the patient's body or in the question is very much higher than expected bicarbonate. Possibility 2, given bicarbonate in the patient's body is very much less than expected bicarbonate. On this side also, given CO2 is very much higher than expected CO2. Given CO2 is very much less than expected CO2. So when there is a mixed acid base disorder, given and expected are not correlating, these can be the mathematical possibilities. First, let us see a mixed acid base disorder with respect to primary respiratory disorder. Listen very carefully, students. Say for example, there is a patient with COPD. Because of COPD, his CO2 has increased from normal value of 40 to 60. To call it as a compensatory phenomena, bicarbonate should increase from 26 to how much? For 10 it is 4. For 20 it is 8. 26 plus 8, 34. But in the patient's body, now bicarbonate is 38. What does it mean? Body's compensatory response can only bring it to 34. But it has increased beyond that. It means there is some extra bicarbonate in the body. So anywhere extra bicarbonate in the body should be considered as additional metabolic alkalosis. So this is a situation where given bicarbonate in the patient's body is very much higher than expected bicarbonate. It means there is some extra bicarbonate in the body. Anywhere extra bicarbonate should be written as additional metabolic alkalosis. See whether this fellow has vomited. That vomiting must be responsible for that additional metabolic alkalosis. Example clinical scenario, COPD patient who has developed vomiting. Coming to the next patient, this fellow also had COPD. As a part of COPD, his CO2 has increased from normal value of 40 to 60. To call it as a compensatory phenomena, bicarbonate should come to 34. But now, instead of being at 34, it has decreased to 30. What does it mean? Body's compensatory response should bring it to 34. But it has decreased from there. So there is abnormal decline in bicarbonate. Anywhere abnormal decrease in bicarbonate should be considered as additional metabolic acidosis. So this is a situation where given bicarbonate is very much less than expected bicarbonate. There is some bicarbonate decline in the body. Anywhere bicarbonate, abnormal bicarbonate decline should be referred to as additional metabolic acidosis. See whether this patient has developed diarrhea. Example, COPD plus diarrhea. Once again, in very easy words, kindly observe here, students. Whenever CO2 increases to this level, bicarbonate should also come to this level. This is adequate compensation. If bicarbonate increases excessively, any extra bicarbonate should be referred to as additional metabolic alkalosis. If bicarbonate decreases abnormally, any abnormal decrease in bicarbonate should be called as additional metabolic acidosis. Correlate with history, you will get the answer. Now let us see mixed acid-base disorder with respect to primary metabolic disorder. Now say for example, this patient is having diabetic ketoacidosis. Because of diabetic ketoacidosis, his bicarbonate value from normal value of 26, it has decreased to 10. To call it as adequate compensation, what should happen to CO2? Expected CO2 1.5 into bicarbonate plus 8 plus or minus 2. It should come down to at least 21 to 25. But in the patient's body, now CO2 is 34. What does it mean? Body's compensatory response should bring it to 25. But it has increased excessively. Any extra CO2 in the body should be considered as additional respiratory acidosis. This additional respiratory acidosis is very much relevant in DKA, because in DKA there is a complication called as diabetic ketoacidotic coma that can result in respiratory depression. Gradually CO2 will increase. If you identify this patient early and if you intubate him, he will survive. So this is a situation where given CO2 is very much higher than expected CO2. It means there is some extra CO2 in the body. Anywhere extra CO2 should be called as additional respiratory acidosis. The clinical scenario here will be DKA with altered sensorium. This patient must be going into diabetic ketoacidotic coma. Coming to the next patient. So this patient is also having DKA. Because of DKA, his bicarbonate has decreased to 10. To call it as a compensatory phenomena, CO2 should come down to 21 to 25. But in this patient's body, it has decreased to 15. What does it mean? Body's compensatory response should bring it to 21, but it has decreased beyond that. So it means there is extra CO2 washout from the body. Anywhere extra CO2 washout from the body, it is called as additional respiratory alkalosis. See whether this fellow, because of panic, he is hyperventilating excessively. Given CO2 is very much less than expected CO2. It means there is extra CO2 washed out from the body. Anywhere extra CO2 washout is additional respiratory alkalosis. Example, DKA with anxiety. Once again students, in very easy words, observe here. Whenever bicarbonate decreases to this level, CO2 should also come to this level. This is adequate compensation. If at all CO2 has increased excessively, any extra CO2 in the body is additional respiratory acidosis. If CO2 has decreased excessively, any extra CO2 washout is called as additional respiratory alkalosis. Correlate with clinical history. You can easily interpret the mixed acid-base disorder. Now if you do some questions, you can answer this concept better. So I'll give you 3 questions. Apply algorithm and try to identify what is the disorder here. First patient, he is with DKA. These are the parameters. First, see the pH, draw arrow marks. Number 1. What is this? Acidosis or alkalosis? pH is reduced. It is acidosis. Second step. What is primary? Change is in same direction. So it has to be metabolic. Third step. Calculate compensation. Because it is primary metabolic, I have to calculate respiratory compensation. What is the formula? Expected CO2. 1.5 into bicarbonate plus 8 plus or minus 2. So 15 plus 8 plus or minus 2. 23 plus or minus 2. It has to be in the range of 21 to 25 mmHg. Now if you notice, this is a situation where given CO2 in the patient's body is correlating with expected CO2. So if given and expected are correlating, it is adequate compensation. So the answer is metabolic acidosis with compensatory respiratory alkalosis. So this is a simple acid-base disorder. Second patient, DKA, is anxious. These are the parameters. Again draw arrow marks. Reduced, reduced, reduced. See the pH. It is acidosis. What is primary? The change is in same direction. So it is metabolic. So whenever you have a primary metabolic acidosis and bicarbonate has decreased to 10, CO2 should come down to 21 to 25. but here CO2 has come down to 16. This is a situation where given CO2 in the patient's body 16 is very much less than expected CO2. So it means there is some extra CO2 washout from the body. Any extra CO2 washout should be referred to as additional respiratory alkalosis. So this is a mixed acid base disorder. What might be the reason for this additional respiratory alkalosis? Patient is anxious. He might be hyperventilating in panic. Then coming to the third question. Patient with DKA, altered sensorium. Again draw arrow marks. Reduced, reduced, reduced. Anywhere reduced pH is acidosis. What is primary second step? It is in same direction. So the name metabolic. In a primary metabolic acidosis, when bicarbonate is reduced to 10, CO2 should come down to 21 to 25, but here CO2 has ultimately increased to 34. This is a situation where given CO2 in patient's body is very much higher than expected CO2. It means there is some extra CO2 in the patient body. Anywhere extra CO2 should be called as additional respiratory acidosis. So what might be the reason for this additional respiratory acidosis? Patient is in altered sensorium. He must have been going into diabetic ketoacidotic coma. Now if you identify this patient and intubate him early, he is going to survive. Next, coming to ABG sampling students. You only tell me what blood is taken, arterial blood, and which artery is generally chosen. For accessibility, we choose radial artery. So whenever I want to puncture radial artery, I have to make sure my ulnar artery is patent. Why? Whenever I puncture my radial artery, transiently blood is not flowing here. If my ulnar artery is not patent, these fingers will develop ischemia. So what is the simple bedside test for patency of ulnar artery referred to as? It is modified Allen's test. So what you do is you are going to block both the arteries. So radial artery and ulnar artery, and you are going to close your fist. So once after some time you open your fist, because you have blocked both arteries, your fist will be very, very pale. Now what you are going to do, you are going to release the pressure from ulnar artery. On release of pressure from ulnar artery, if your hand turns pink, it means ulnar artery patent. Ulnar artery patent means Allen's test positive. Allen's test positive means you can poke this adjacent radial artery. Just write down. I'll discuss once again. ABG sampling. Most commonly radial artery used. We are going to do modified Allen's test for patency of ulnar artery. The important steps here will be on release of pressure from ulnar artery. If hand turns pink, it means ulnar artery patent. Ulnar artery patent means Allen's test positive. If Allen's test is positive, you can poke that adjacent radial artery. If you observe here, everything starts with the letter P. Once again, see here, on release of pressure, see, you are opening your hand, now it is pale. On release of pressure from ulnar artery, if your hand turns pink, it means ulnar artery patent. Ulnar artery patent means Allen's test positive. Allen's test positive means you can poke this corresponding radial artery. So everything starts with the letter P. If Allen's test is negative, you should go to the next radial artery, or you should go to the femoral root. Before taking the blood into syringe, something should be added into the syringe. What is that? Heparin. How much heparin? Write down. 0.12 ml heparin is used for ABG sampling. So why heparin has to be used? Because if the blood is clotted, the sample is waste. So the ABG mission cannot process clotted blood, and by giving heparin, it is an anticoagulant. It will maintain the blood in liquid state. It will not allow it to coagulate. So with this, we are done with majority of acid-base balance and respiratory medicine. Before I conclude, I would like to do some practice questions, because to become a master in ABG, the more you practice, the more you will succeed in your exams. And after this video, also watch that ABG Extra Edge video, which will be uploaded in coming days. So it will have more practice concepts and practice questions. So let us see few important questions. So don't forget to watch this ABG Extra Edge video, which will be uploaded very shortly. So it will have more practice concepts and questions. Now let us see some basic questions which I have asked previously. A 20-year-old anxious female, with chronic hyperventilation, ABG results are given. What is the abnormality? Whenever you see any ABG, first history-wise approach. What can be the possibility? So this is an anxious female. History-wise, what can happen in them? With chronic hyperventilation. What can chronic hyperventilation cause? Chronic respiratory alkalosis. Now confirm this with ABG wise approach. pH 7.48, PaCO2 25, bicarbonate 20. Quickly draw arrow marks. Increased, reduced, reduced. So anywhere, first step, see the pH. Increased pH is alkalosis. What is primary? Change in pH with respect to parameters. It is in opposite direction. So what should be the primary? Respiratory. So the best answer is respiratory alkalosis. Now these are level 1 questions. Limited history and limited steps. In the last 2 years, there were 4 ABG questions, and everything were level 1 questions. You are expected to know whether it is acidosis or alkalosis, whether it is respiratory or metabolic. That was sufficient. But we will also see higher level questions, so that we'll be prepared for any question regarding ABG. So this is level 2 question. More history and more steps. A patient with amyotrophic lateral sclerosis brought to clinic who are worried that he is more somnolent than normal. Lot of history and ABG parameters are given. What is the disorder? Now coming to history wise approach. So what can amyotrophic lateral sclerosis cause? It is a chronic neuromuscular disorder. It can cause chronic respiratory alkalosis. Then coming to ABG wise approach. pH 7.34, PaCO2 60, bicarbonate 34. Quickly draw arrow marks. Reduced, increased, increase. Stepwise ABG. See the pH. First step, acidosis or alkalosis? Acidosis. Second step, what is primary? The change is in opposite direction. So it has to be respiratory. Acute or chronic? Chronic. Third step, calculate compensation. Here CO2 has increased from normal value of 40 to 60 by 20. To call it as adequate compensation, bicarbonate should increase from 26 to how much? For 10 it is 4, for 20 it is 8, 26 plus 8, 34. Given value, expected value correlating. So it is chronic respiratory acidosis with compensatory metabolic alkalosis. In simple words, it can be written as compensated respiratory acidosis. Compensated respiratory acidosis. Next question. A 6-year-old child being evaluated for persistent metabolic acidosis. Lot of parameters are given. They're asking you to see the anion gap. Let them give whatever they want. For anion gap, we will only use these parameters. New formula. So how much is sodium? 140. How much is chloride? 112. How much is bicarbonate? 16. So it will be 140 minus 128. It will be 12. So it is a normal anion gap. So this is a normal anion gap. Next, patient with renal failure develops vomiting in ICU. You performed an ABG and this is the result that you are getting. What is the disorder? Now first of all, let us see history-wise approach. History-wise approach, this patient is having renal failure. What can renal failure cause? High anion gap, metabolic acidosis, and he is having vomiting. What can vomiting cause? Metabolic alkalosis. Now if you see this situation, it is a very peculiar condition. There are two mutually opposite metabolic disorders. So one is metabolic acidosis and other is metabolic alkalosis. Whenever there are two mutually opposite metabolic disorder, what you can expect the pH to be normalized, because they are two mutually opposite, pH can be normalized. Now let us see ABG wise approach. Writing down the parameters. pH 7.40, PaCO2 40, bicarbonate 25. If I see only these parameters without seeing the history and without seeing that anion gap, my automatic answer will be normal parameters. But there is significant history and very high anion gap. Anion gap is high, 20. So I told you previously, anion gap is generally not incidental. Whenever there is a history, relevant history, it is always significant. High anion gap with relevant history is always significant. So definitely in his body there is possibility of high anion gap metabolic acidosis. So I should consider, because there is high anion gap and relevant history of renal failure, I should consider ongoing high anion gap metabolic acidosis in his body. So I should consider the possibility of high anion gap metabolic acidosis in his body. Now in ABG algorithm, we have an advanced step. Whenever there is high anion gap, you should compare change in anion gap and change in bicarbonate. So you know that there is a relation for every 1 milli equivalent increase in anion gap, bicarbonate decreases by 1 milliequivalent. So whenever there is high anion gap, you should see whether this relationship is satisfied or not. So if you consider normal anion gap as 10, normal anion gap as 10, in this patient the anion gap has increased by 10. So if you consider normal anion gap as 10, patient's anion gap is how much? 20. It has increased by 10. Then if you consider normal bicarbonate as 25, what should happen to his bicarbonate? If anion gap increases by 1, bicarbonate should decrease by 1. It has increased by 10. So bicarbonate must decrease by 10 and it should come to 15. So here the concept is, if it is single high anion gap metabolic acidosis, the bicarbonate should have stayed at 15. But in the patient's body, it has increased to 25. It means there is some other disorder that has added extra bicarbonate to the body. So this is a situation where given bicarbonate in the patient's body 25 is very much higher than expected bicarbonate, that is 15. So it means there is some extra bicarbonate in the body. Anywhere extra bicarbonate should be referred to as additional metabolic alkalosis. Always correlate with history. Is there any disorder capable of adding extra bicarbonate to the body? Yes, vomiting. So the answer becomes high anion gap metabolic acidosis with metabolic alkalosis, with additional metabolic alkalosis. So once again students, the basic concept here is, if it was an isolated high anion gap metabolic acidosis only, whenever anion gap has increased by 10, bicarbonate must have decreased by 10 and it must have stayed at 15 only. But in the question, bicarbonate has been increased back to 25. It means something has added extra bicarbonate to the body. Anything that adds extra bicarbonate is called as additional metabolic alkalosis. Correlate with history. Is there anything that can add bicarbonate to the body? Yes, patient is having vomiting. So it is high anion gap metabolic acidosis with additional metabolic alkalosis. So once again the basic concept here, if it was an isolated single high anion gap metabolic acidosis, when anion gap has increased to 20, bicarbonate should have stayed at 15. But it has come back to 25 in the patient's body. So it means something has added extra bicarbonate. Anything that adds extra bicarbonate is additional metabolic alkalosis. You can correlate with history also. So even if you get any complex question, if you follow algorithm, you will get the answer. So last question, it includes all ABG steps. 84-year-old male with diarrhea was found to have blood pressure. A lot of values were given. What is the acid-base disorder? Now history-wise approach. What can diarrhea cause? Diarrhea can cause normal anion gap metabolic acidosis. Then ABG wise approach. pH 7.29, PaCO2 24, bicarbonate 10. Quickly draw arrow marks. Reduced, reduced, reduced. Step 1, see the pH. Acidosis or alkalosis? Acidosis. Step 2, what is primary? The change is in same direction. So it is metabolic. Step 3, calculate compensation. This is metabolic acidosis, so respiratory compensation. If I apply this formula, 1.5 into bicarbonate plus 8 plus or minus 2, expected CO2 will be 21 to 25. How much is given? 24. Expected correlating. So it is metabolic acidosis with compensatory respiratory alkalosis. What is step 4? Calculation of anion gap. How much is the sodium? 137 minus how much is chloride? 117. How much is bicarbonate? 10. So it will be 137 minus 127. It is 10. So put it together. This is normal anion gap metabolic acidosis with compensatory respiratory alkalosis. So it is non-anion gap. It means it is not high anion gap. It is normal anion gap metabolic acidosis with compensatory respiratory alkalosis. So with this we have concluded respiratory medicine and acid-base balance. So I hope you have enjoyed this session, students. So whenever I complete my session, especially boys will come and ask me, sir, why is it very important to get into post-graduation? Give us some motivation quote so that we'll start studying from today onwards. Now this is the best motivation quote I have found till date. Actually it worked for me also. In our country, MBBS degree will only give you pride, but it is good PG degree that will ultimately get you good brides. So if you want to get a good bride, you should have the PG degree. I hope this will serve as motivation to everybody. Thank you so much, students. If you are having any doubt, you can mail me. So this is my mail ID, bharat.svmc@gmail.com. So you can contact me on Facebook with the same name, Bharat Katti. So I think we have done in a very conceptual manner, and we have also done so many clinical cases. All these clinical cases will be uploaded in the app. Thank you, students, and all the very best.